I want to start off with a case vignette, all right? Now, this is a 75-year-old female, all right? She has a history of hypertension, hyperlipidemia, diabetes, chronic kidney disease. Sound like anybody you know? Okay, all right. Now, she comes into the emergency department, and she comes in for new onset dizziness, some shortness of breath, and palpitations. They started 3 hours ago, so she recognized this, okay? And she was gardening, all right? She didn't have any chest discomfort. She didn't lose consciousness or anything along those lines. So you can read her vital signs. The thing that's low, obviously, is her blood pressure, and her rate is really up there. So this is her baseline blood pressure. So she's obviously hypotensive. She's got a grade 1 over systolic murmur at the left sternal border, which is not unusual for elderly individuals because you have this mitral annulus that almost surrounds the mitral valve, and as we get older, besides everything dropping down and whatnot, that gets calcified. So it's very common to hear this murmur of mitral insufficiency. Lungs are clear, so she doesn't have any signs of any pulmonary edema or anything along those lines. So in the emergency room, they give her some fluids. Here's her EKG. So those of you that are expert in this will know that it's irregular, okay, and you've got no discernible P waves. Does anybody else see any kind of major things on this EKG? Those of you that are the experts here. What have you got? I can't hear you, I'm so sorry. Excellent, excellent. LVH, you know what? Quick and dirty on any EKG, and it holds true a lot of the research studies. If you take the sum of the height of the R wave in V5, in other words, you count all those little boxes, okay? The sum of the height of the R wave and the S wave in V1, if you count up all those boxes, if it's greater than 35, more than likely, 90%, you've got left ventricular hypertrophy. And she has a history of LVH. So if you did a two-dimensional echocardiogram on her, you'd probably see a thickened, septum and posterior wall. So moving on here, we hope. All right, so and we're going to come back to this. So I just want you to think, if you were, because this is supposed to be from, acute to primary, primary to acute lecture is what they told me. So thinking about this, what are you going to do with this individual? And we will come back to this case. Now, I want to put it into a primary care practice. You've got someone that's 82 years young, okay, presents to your office. They're coming in for hip pain, maybe some bursitis or something along those lines, arthritis. What's the chance that this person has atrial fibrillation? What percent would you give that? We don't have any of those clickers here, so we'll just have to, in our heads do this thing. So when you look at the studies, basically, the older we get, the more likely that the person is going to develop atrial fibrillation. Not unlike what we know, okay? So at least 10%. So about 1 out of every 9 to 10 people that you see can have atrial fibrillation. So now we have a 42-year-old male that comes into the emergency department. They have chest discomfort. What's their lifetime risk of developing AFib? Well, when we look at those studies, it's basically 1 in every 4 individuals, okay, men and women, all right, can develop atrial fibrillation. So what I'm saying is this is hugely common, okay? Really, really common. So 25% is the answer to that question. So when we look at this, and I'm sure the numbers are even more than this, because we have to turn these slides in months ago, that we have millions of people out there with atrial fibrillation. It's a huge problem, to say the least, okay? So the prevalence starts to increase after 40, youngin' folks, right? And it rapidly rises over the age of 65. So that AFib is more prevalent in men than it is in females, but trust me, most of my patients in the cardiology practice with AFib, there's tons and tons of women. All right, so when we look at all the trials that have been done in cardiology, and there's a lot more than this, you'll see that the more severe in somebody with heart failure, the higher the incidence of AFib. So what are the most common conditions that we see with atrial fibrillation? And I think what this slide basically tells me that if I have somebody coming in with any of these diagnoses, all right, that I'm going to think and I'm going to do a really good exam on these people to pick up atrial fibrillation, because a lot of people have no clue that they have irregular heartbeats or extra beats, as you well know. So hypertension is really the most common cause. Certainly ischemic heart disease, mitral valve disease, hypertrophic cardiomyopathy, the dilated myopathies. Less common are these types of diseases that you'll notice atrial fib in. Obstructive sleep apnea, certainly, and that's why we always do sleep studies on people that have got atrial fib, and also heart failure. They should all have sleep studies, okay, because a lot of them have the central sleep apnea. Okay, and obesity. A lot of studies out there showing that the greater the weight loss, the less the incidence of atrial fibrillation, for a whole variety of reasons, because obesity in and of itself is a pro-inflammatory state. And here's one of the many studies that was done. This is an older study, but there's a lot of newer ones that are out there that show that sustained weight loss and exercise can definitely decrease the burden of atrial fibrillation. These are some independent predictors and also dependent predictors. Aging, obviously, is one of them. Heart failure, COPD, obstructive sleep apnea is another. Alcohol, and we'll talk more about alcohol as it is, okay? There is the Hatch score, which is a pretty good predictive score to tell your patients their progression from they may have paroxysmal atrial fibrillation on to permanent AFib. And this is kind of a scoring system to say, hey, look, if you're elderly, over the age of 75, hypertension, you may have had a TIA or a stroke, COPD, heart failure, high risk of going on to develop atrial fibrillation. So why so much atrial fibrillation? What are some of the main causes here? Basically, if we concentrate on this atrial structural abnormalities, fibrosis, dilatation of the atria, and that's why the normal atrial size on a 2D echo is 4.0 centimeters. And the more dilated that is, the harder it is to get somebody back into sinus rhythm. And that's why a lot of people, after you cardioverse them, they'll go right back into sinus if they have large atriums. And that's why if somebody's got a 6.0, we don't even, you can try, but usually cardioversions don't work on these individuals. Okay, so there's a lot of extraneous factors that we already talked about here. The inflammatory state that this causes here, remodeling. Once somebody goes into atrial fibrillation, that atria starts to remodel rather rapidly, and it takes a while to come out back to normal atrial contraction as such. So that we've got a lot of abnormalities here that we're dealing with. Wine, unfortunately, is at the top of the list. If you look, and I just went to cardiology in Cancun, that's a really good conference to go to. They do. It's really kind of cool because, one day it's heart failure, the next day it's arrhythmias, and et cetera, et cetera. So, and they presented all the studies on this, and it's really true. 1 or 2 glasses of wine, particularly every single day, is not good for something like atrial fibrillation. And wine, believe it or not, stays in your system, or alcohol stays in your system for days. It doesn't wear just off. You physically or mentally, it might wear off in a few hours. The buzz is gone. But the alcohol literally stays in your system for a couple of days. So this is one of the big things that you have to unfortunately tell people that, and even after ablation, when you look at those studies, when they've done the ablation, these people are in sinus rhythm, alcohol is still kind of a bandit, to say the least. A bad thing as such, okay? So these are some of the mechanisms of alcohol. It's really interesting when you look at alcohol and cardiomyopathy. I have patients that would drink a quart of bourbon every single day and their heart's function would be fine. And then I'd have other people that have occasional wine or whiskey, and they'd have this dilated heart with very low ejection fractions. So it's interesting how it changes with different body types and whatnot. So electrolyte imbalance for sure, particularly the alcohols. They're not going to be, you know, if you're going to be drinking all day, you're not going to be eating a lot, and your protein levels are going to go down, prealbumin, and all sorts of other issues that you can have associated with that. And then high blood pressure and alcohol goes hand in hand.